And let's just go ahead and start. Hi, everyone. I'm Shelly Shor. For those of you who do not know me yet, I'm the program manager for operationalizing peer support for the Healthcare Authority. In my previous position, I was a clinical supervisor for the peer team and a peer therapist for the a large behavioral health agency in Pierce County. I'm a social worker and I'm a parent peer. I'm a CPC, and I'm here today to talk about the peer role because a lot of you wanted more clarifications, and I got some really formal and really non-formal things to share with you. And so I hope this will be a good day for us all, or at least a good hour. I'm going to pause for questions here and there. Feel free to write things in the chat. I had an idea to put some Menti activities here to know who's in the room, but I'm a little scared now because of technology and internet. So I will not do that today. If by the end of the webinar, I'll see that things are going well, I'll do some of that, at least to gauge some ideas for our next webinar. So good morning. Feel free, if you want, to unmute yourself and say hi. Hi, or not, or jazz hands will work as well. Yeah, we all love those. Thank you. And I will start today. Let me share my screen. I'm a little excited about this because it's always something that a lot of people ask me about. Let me see, where can I share? Okay. Getting jiggy with it. Okay, we got this. I hope everyone can see my screen. If you can thumbs up me, if you can. Thanks, Kenneth. Thank you, everyone. Okay, let me just do this. I don't need this. Okay, so certified peer counselors in Washington State and the peer role. I always want to start by saying, you know, why are we even doing this, and what's the value of the peer services? And the value is great, and those of you who are here, I hope you know that. But I do want to spend a couple of minutes talking about the peer services as an evidence-based practice. So there is a growing body of literature that is increasingly being able to demonstrate positive outcomes for people receiving or utilizing peer support. The research shows groups of people that have received peer services versus people who did not receive services from peers. And the reports show positive measurements in both objective and subjective measures. And so some of the objective measures that were found were lower rates of hospitalization and days spent in inpatient settings. We all know how valuable that is for everyone. We saw decreased use of emergency rooms, decreased substance use, and reduced overall symptoms. And those are just a few of the objective measures of utilizing peer services. These subjective measures that are as important are people's feelings of being cared for, people's feelings of having hope, and the engagement in services. That is, I think, both objective and subjective, feeling that someone cares for you. And so these results show that we need peer services. And we do see more and more organizations utilizing peer services. But we also hear a lot of, you know, about the gap between, okay, I have peer services, but what are we doing with peer services? And so this is why I'm here today, to explain a lot of the things that have to do with the peer role. And I want to explain that to both supervisors, program administrators, and peers that are here with us today to empower and educate and share some of that information. So a few definitions. A peer is a person with lived experience with behavioral health. A peer counselor is a person with lived experience who provides peer support services. Certified peer counselor, CPC, is a person with lived experience who has completed a state-approved training and has passed the state exam. Youth peer is a person who has lived experience as a youth with behavioral health recovery. A parent peer is a person who is parent or guardian or a person with behavioral health challenges. And peer support services are services provided to an individual by a peer counselor. I will just say, I will be sending these slides to everyone in here today, so we don't have to take notes or bother about any of that. I like to share Sharing Needs' definition of peer support. Peer support is a system of giving and receiving help founded on key principles of respect, shared responsibility, and mutual agreement of what is helpful. I like this definition because it is also very subjective, and I like subjective things because for everyone help is different. And so we don't just prescribe a unified help, but we see what is helpful, and this is what peers work with. Peer support in behavioral health, according to SAMHSA. Peer support workers are people who have been successful in the recovery process, who help others experiencing similar situations. Through shared understanding, respect, and mutual empowerment, peer support workers help people become and stay engaged in the recovery process and reduce the likelihood of relapse. In Washington State, we were the 11th state to add peer support as a Medicaid reimbursed service. And in 2019, we added SUD peers as a Medicaid reimbursed service. You can read a little bit more about it if you want. I will say that we did have peer supports way before that. It was just not Medicaid reimbursed. And we still today have both services, one that is Medicaid reimbursed and the others that are not Medicaid reimbursed. I also want to say that some of the things that I will share in the next few minutes are more relevant for Medicaid reimbursed services. However, if you are in a non-Medicaid reimbursed service and providing peer services or supervising peer services, these things are still extremely relevant, in my opinion. They do give some guidelines and some ideas and some, more of the theoretical point of view of what a peer is. So we have the state plan that basically describes the mental health peers and the SUD peers, and basically what they do, it's very similar as far as both need to be self-identifying as as consumers or survivors of mental health services. I want to mention here the language in the state plan is still very dated. We have some words there that we don't use today in the peer world, like consumers. And these, again, things that were written in that plan several years ago, and hopefully with time we can change the language a little bit, because we all know how language is very and extremely important. Another thing that is shared in the state plan that the peers need to be in recovery for at least 1 year. They have some a range of tasks that they assist other people with, and they need to be clinically supervised by an MHP for the mental health peers and SUDP for the SUD peers. And this is also a very charged topic. We do know that the clinical supervision needs to happen. We don't know the frequency of that, the duration, any of that is, all of this is very vague, and there are many ways to go about it. And we can talk about it more if you have questions afterwards. And in a few minutes, I will pause for some questions if you have any, or if you want to write them in the chat or unmute yourself and ask. We will do that in a couple of minutes. The WAC is the Washington Administrative Code. It basically codifies all the regulations and arranges them by topic. We have WAC 246-341-0724, again, for Medicaid reimbursed services of peers. And it basically talks about outpatient services, recovery support, peer support, behavioral health services. And it says peer support services provide a wide range of activities to assist an individual in exercising control over their own life and recovery process through A, developing self-advocacy and natural supports, B, maintenance of community living skills, C, promoting socialization, and D, the practice of peer counselors sharing their own life experience related to mental health to build alliances and enhance the individual's ability to function. So we see here again, there are a lot of the topics and ideas that we know that peer supports are supposed to do when working with people that they serve. It is a little bit specific and a lot vague. So there are a lot of things that can be included in this, and this is where we work with the person that we serve on finding those things that are specific for that person. The second part of the WAC talks about the agency providing the peer support, and they must ensure that the peer counselors are recognized by the healthcare authority as a peer counselor. But the more important thing for me, and maybe for us, or maybe not, is B, that provide peer support services within the scope of the peer counselor's training. And this is important, and this is what we're talking about today. We're talking about providing services within the scope of the peer counselor's training. We'll definitely go deeper into that in a few minutes. And finally, one more slide, and then we can pause. The theory is the service encounter reporting instruction, and it provides instructions on how to provide services that are Medicaid reimbursed and how to document that. And so with this, peer services are services provided by peer counselors to individuals under the consultation, facilitation, or supervision of a mental health professional who understands rehabilitation and recovery. I'll pause here and say, you know, I hope that in time, a lot of the supervisors can be peers or go through the CPC training to understand rehabilitation and recovery and to understand the peer role a little bit better. But until then, we are counting on those supervisors to be champions of peers and understand everything that they need to about the peer role. The service provides scheduled activities that promote socialization, recovery, self-advocacy, development of natural supports, and maintenance of community living skills. Consumers actively participate in decision-making and the operation of the programmatic support. Again, language, but we get the point. How about I pause here for a second and see if we have questions or comments or anything that we have in the chat right now. Amanda, can you see if there's anything, please?
Hi, Shelly, I don't see any questions in the chat. A lot of really great comments, everybody introducing themselves, but no questions as of yet. Please, y'all know that if you do have questions, you can raise your hand and we can address them, or rather, Shelly can address them as we're moving forward. Oh, let's say. Oh. Rebecca wants to know if they can if she can have a link to the recording for later.
Absolutely. Once we're done here, I will send the PowerPoint and the link for the recording. Actually, the recording will take probably a few days, so I can just wait for that recording and send everything together, so you won't get too many emails from me. But yes, the answer is yes. Thank you. And Amanda, thank you for fielding all the questions. Amanda Paul, if you don't know her, she's the Superstar Peer Program Administrator, and she is supporting me today. Okay, So how about we continue? I think we're going to have some more questions as I reach more controversial topics in a few minutes. And so again, I'm going to go over some things that are the peer role. When most people on the team focused on symptom management in one way or another, CPCs do not. Instead, they work to help people overcome the effects of poverty, trauma, and abuse, and the effect of stigma and discrimination. They do so by sharing their life experience with hope and skill building. Peer support, as I mentioned, is extremely flexible because while peer support is all under the umbrella of the WEC, the tasks assigned by the WEC are broad enough for CPCs to meet people's needs while meeting Medicaid standards. I had something I wanted to say about that, but it went away. I hope I find it again. Okay, I found it. So what I wanted to say, I heard a webinar by Patricia Diggin, a great peer supporter and one of the pioneers in this field, and she was saying, the peers are the ones in charge of bringing the story, the narrative, into the clinical conversation. So while everyone else on the team is talking about symptoms, is talking about things that they can observe and see from meeting the person that they are serving, the peer is the one in charge of bringing that, like I mentioned, the narrative, the story. And the peers are part of the culture shift sometimes in organizations when the culture is more about symptoms, more about the medical, more about the clinical. The peers are creating a shift into the personal and the narrative and the story. And so we want to remember that as well. Peer services include, but have much, much, much more than that, identifying strengths and setting goals led by the person receiving the support. Really important point. We want to have that person defining what their goals are. Recovery and wellness planning and ongoing recovery management, promoting hope through sharing of lived experience. And when I say promoting hope, when a peer arrives to an agency, they are, I mentioned that, they are shifting the culture, but they are showing that recovery is possible. They are a lived experience. And so they are modeling that for the people they serve, for their families, but also for providers, other providers. And we know there are a lot of providers that maybe still don't believe in recovery. There's still a lot of stigma. So peers are there to break that stigma, to bust those myths, and to show hope that recovery is real. Peers also connect to community resources and supports, and that's a big part of the peer world. We want the peers to be out there and supporting people in the community. Excuse me. Peers provide education on self-advocacy skills, teaching daily living skills, health system navigation, because peers were there and they know sometimes more than anyone else who they need to reach, when, how. And they also facilitate recovery groups. Peers are more than capable of providing recovery groups and facilitating them. We do not want peers to do clinical groups. For example, this might be controversial, but we don't think that peers need to do a CPT, CPT group, CBT groups, DBT groups. We want peers to do RAP groups and other groups for self-advocacy, empowerment, anything that you can think of that is more peer-related and non-clinical.
Hi, Shelly. There's a couple questions, or comments as well, but Christy would like to know if you would be able to supply the research quoted that shows the evidence-based practice outcomes for peer support. A couple of us, including Ben, added a couple of links, but if you have any additional ones,
Yes.
that you want to send out in the follow-up email, that would be great, or maybe pop into the chat.
Absolutely. It's a little difficult for me to pop them in the chat right now. I will definitely put them in the resource area in the slideshow and write specifically, this is the link for the evidence base, so you don't have to go over all the links. But I have a couple of resources for that. One of them is basically a booklet, how to get management buy-in to peer services, and there's a lot of material there on evidence-based, and John Caldwell actually deserves the credit for providing me with these resources. So thank you, John, and I will definitely provide the links.
Thanks, Shelly.
Thank you. Here is a very wordy slide about peer support workforce competencies. Some of you might not be able to see that, and I apologize. You can see it in your PowerPoint when I send it. But the idea is that moving up from general worker competencies up to the peer support workforce competencies, we can see ability to use your own experience to inspire hope. I can barely read it myself, I apologize. And belief in recovery, support self-determination through connections from a mutual stance, facilitate self-exploration and discovery, act as a change agent to support environments, systems, and approaches to move forward. And you know, if anything out of this day that you might want to take with you is just inspiration on how the peer role is so unique, is so important, and it doesn't need to be any other thing than what it is. I'll share more about it in a few minutes. I do want to talk about what the peer role is not, because this is also a very, very important thing that a lot of people do not know. And a lot of people know and can talk about it. So I'm not assuming anything about anyone. I'm just saying this is a lot of questions that I've got are, what is not the peer role? And here are 3 categories that the peer role is not. And I want to share an example for each and every one of them. Let's start with busy work. Ask yourself, is this just busy work because you don't know what else to give to the peer to do, or there's no one else who wants to do this particular task? If this task is not recognizing the special skills of the peer or their training, then it's just busy work. Let's go to an example and then go back to the second category. Example is giving rights. So we all know, you know, that we do give rights sometimes, right? So it's a tricky one. But the idea is that, is there an additional value in these rights? Is it consistent with what the goal is, the goal of the person receiving the service is? Some of the things that I wrote in this example, right, these are some of the things. The question is, you know, did the request come from that individual, or someone else asked you to do that because no one else can do it, or you have spare time? Is it routine? Is it occasional? Can you sit in that ride and talk about things that are relevant for the peers that you are serving? Are you taking the bus with them to show them the route? So that is good, valid, important work of the peer. But is it just for giving rides because no one else can do it, or you have time? Then that's busy work. And we do not encourage that. The second category is agenda. In agenda, we're basically asking the peer to focus on a particular agenda that is not the person that we are supporting. Is it just a way to get information for the rest of the team? And is it just defined by someone else? Again, that is not the peer. An example of agenda is a group participation. I give this example all the time. You might have heard it before. When another service provider asks a peer to convince a participant to attend a group when the participant expressed they're not interested in. So the provider thinks this is a great idea. They have to be there. Also, I have 8 spots left, and if I can't fill them, I can't open the group. This is an agenda of that person that is doing the group. The peer might think that this is an amazing idea to participate in the group. With that said, they cannot convince the people that they're working with. They can hear why they don't want to. Maybe there's a fear that can be addressed. They can share how this group have helped them in the past, but convincing someone for someone else, it's just an agenda item for someone else, and we do not encourage doing that. The third category is power imbalance. So are we asking a peer to do something that will increase the power imbalance or create a power imbalance between them and the person they're serving? Let me just say the peer relationship with the person that they're serving is very reciprocal in some ways, but let's not lie to ourselves. There's still a power imbalance. The peer is still getting paid for this service. The peer is still in charge of a lot of the boundaries. And so there's a certain power imbalance. The idea is not to increase that power imbalance. So one example is medication, and again, a little controversial, but the idea is that medication are still they're tricky. They're still increasing the power imbalance. If I'm in charge of your medication, and I'm the one that is in charge of what's this word that I'm looking for? It will come to me, you know it. Basically, the idea is you cannot be the one in charge of something for the peer that you are serving, and medication is one of them. And you
can I ask a question, Shelly? Sorry to interrupt, but I am curious.
Oh, no, of course.
Is there any special skills or tips that you have for everybody on the call on how to identify and mitigate those power imbalances with peers in service and peers who are offering service?
Good question. Thank you, Amanda. So let's go back to power imbalance. Let's go back in here. So here are some things. I think we need to, first of all, understand that there is power imbalance. We need to realize that as peers. When we meet with a new person to us, a person that we serve, a person in services that we work with, there are some things that needs to be discussed from the beginning. I think that putting those boundaries out there is very important and very smart and very tricky and very hard. And so I think you said it once, Amanda, when we have a person that we work with, we need to make sure that we can be friendly, but we are not friends, right? These are your words that I'm quoting right now.
Exactly, yes.
And that so I would say it like this, okay? But it's just an example and you don't have to do it, and it's just me and it's just on the spot kind of thing. I would say, I am so excited that we can work together. I think it could be a little bit tricky if you haven't had a peer before. I will explain my role. I am here to work with you on anything that you want to. I'm here to listen to your story. As a peer, I will also share some parts of my story that I find relevant. And it could be confusing because we are working together. I'm sharing my story. You're sharing yours. I'm not your therapist. I don't want to be your therapist. And so there will be some times that you will ask yourself, are we friends? Can I call you at any time? Can we do this? Here are some things that we could do. And here are some things that I don't feel like is a good thing for our relationship to do. We should talk about boundaries as well. And I'm just going to pause my quote here and say, boundaries are wonderful when they are staying the same throughout the relationship. Any change in boundaries is confusing and potentially traumatic, because a lot of the time changes in boundaries for people resulted in traumatic events. And so I just believe in open communication and talking about these things from the get-go, and also asking the person in front of me, what are your expectations for this relationship of ours, for our working relationship, for this moving forward? Because a lot of the things that that person will tell you will explain to you what their needs and hopes are, and you can adjust through that and say, yes, this is exactly what I'm thinking, and here's I was working with other people in these areas, on these things. Or you could say, I do understand the expectation, to be in touch and for me to maybe attend some of the celebrations of your family. And sometimes, it really depends on the context and the agency's policies, but a lot of the time this is not something that we'll be able to do. I do think that you as a peer need to know what the boundaries of your role is according to your agency's policies, first and foremost. And what are the things that you are comfortable with as an individual, because this could also change the relationship. I know this is vague a little bit. So my recommendation to sum it all up is talk to your supervisor about, first of all, about your boundaries and the boundary of the role and the relationship as they see it, because it is tricky. And I encourage supervisors to create a safe environment to talk about it, and talk about it, as part of the onboarding of the peer. This is the role, these are the boundaries, these are the values and ethics, and let's talk about it when we have a question. So my answer was very general, but we want to take it to the more individual and personal when we work in our diverse agencies and organizations. I hope this is clear. Probably not 100%, but this is what I have. Amanda, do you feel like this will suffice for now?
Yes, absolutely. Thank you for clarifying. I feel like sometimes maybe we're not entirely sure, as from the provider piece, it can be difficult to not be kind of somewhat pleased when somebody says, hey, I only want to meet with you. And then there comes those power exchanges, there comes the boundaries, let's be friendly, not friend situation. And so it's really, it was a good, and I really feel like that should be something that everybody is really digging at to try to figure out where they would like to be and where they would like not to be in their services.
And when someone also wants to meet only with the peer and not with the rest of the team, sometimes that's an agency's policy. And also with Medicaid, that's a must. They have to meet with another provider to write the treatment plan. But there is a wiggle room, but there are some things that we can't wiggle, if it makes sense. So again, very individual according to your agency and the policies of your agency. So I'll just move forward a little bit. Okay, this is an important slide. And these are some questions to ask yourself when you're doing your work, or when you are a supervisor and you are working with a peer and you're not sure, is this a peer work or not? If the answer is no to any of these, it might not be peer support. So is the service voluntary? If it's not peer support. Now, I have questions from peers in the legal system or the court system, and they say, well, the person that I work with is mandated to work with us. And so the answer is the person might be mandated to work with a service provider and the peers are part of that team. But as a peer, the most important value is that this is a voluntary service. And so if the person doesn't want to work with the peer, we cannot make them work with a peer. We can do what we call assertive outreach and say, hey, you don't want to work with a peer. I totally get it. How about, is it okay with you if I ask you again in a week? Sometimes things change, but eventually, and if a person doesn't want to work with the peer cannot force them to work with them. It is a voluntary service. So if the answer is no, it's not peer support. Is the service support, is the service is non-clinical in nature or clinical? If it's clinical, it's not peer support. Is the service focused primarily on a relationship versus one action? If it's just one action, if I need to do this and I must need to do this with the person, regardless of the person's goal, then it's not peer services. This is more like the agenda item that I was mentioning before. Is the peer support focuses on the person's goals or not the agency's goals? Does the support reflect the values of the peer support? And some of those values are use of self, loyalty, autonomy, person-driven, hopeful, strength-based. If it's not peer support. Does the peer support specialist disclose personal experience of overcoming life-altering challenges? If they do, it's great. When they do, however they want to do that, but some elements and aspects of that need to be happening. If not, it's not peer support. And another clarifying slide shows the distinction between peer-delivered peer support or a service provided by a peer. This is super tricky and very confusing, but here's the idea. If I am a peer identifying as, let's talk about me. I'm a parent peer. I identify as a parent peer, but I work right now, obviously in the healthcare authority, or I worked as a therapist in my previous job. I was not providing peer support. I cannot bill for peer support. I was a peer or someone who identifies as a peer doing therapy. A peer-delivered peer support is a peer, someone who identifies as a peer and is delivering peer support, meaning they are working with that person or on their goals, sharing their story, working on empowerment and advocacy and self-advocacy. These are peer-delivered peer supports. And for Medicaid reimbursement purposes, this is something that you can bill in that setting. You cannot bill peer supports. I'm sorry, I need to close this noise. I apologize. You cannot bill for a service if you do not pay. I am sorry, I need to stop sharing this. Okay. I apologize. You cannot bill for services if they are not services that are peer support. I'm going to pause the sharing right now and just tell you, I met with an auditor that was basically auditing a behavioral health environment, and they saw peer services that were billed as peer services. However, they were not documented as peer services, meaning there was no sharing of lived experience. There was none of the work that is identified as the peer work. And so we see these things and they're confusing. Again, this is a very confusing topic. And so this is something to pay attention to. Any questions so far? Because I feel like right now, this is a very, very confusing topic for everyone or for some people.
I have a question. This is Ronita. Can you hear me?
I can hear you.
Okay.
Hi.
So with the peer services, so do the individual that's providing that, because I peer navigator advocates providing services to peers as FCS providers, and they have lived experience. They're certified peer counselors, but they are helping them navigate, connecting to the resources, and meeting them where they are as they help them with their things that they're navigating, maybe with mental health or substance use, but they're sharing lived experience as they helping them kind of navigate what's going on with themselves and offering them, some guidance on things that why they're connecting to X, Y, and Z services, because based on their experience, this is what they did, and connecting to that resource and how it supported them through that similar circumstance that they're helping them with. So that is a peer delivered service, right? Because they're connecting them to that resource based on what they experienced and how they navigated that same situation, a similar circumstance. And that was the connection that they needed. So that would be
Yes.
something that's billable.
I believe so. And I'm open to hearing other opinions, but I believe so. And the reason is that navigation of the system is something that I actually mentioned just before, and you probably saw that. Navigation of the system is a big, important part of the peer role. And so if you are doing that while providing as a service that you provide, while sharing your experience, while sharing the things that helped you, that's definitely something that is a part of the peer role. I believe so, yes.
And one more thing to add on to that. So some of the individuals that we are serving under that employment piece, one of their pathway to employment is that they're identifying that they want to become certified peers. So they're learning as they're working with that peer that's assigned to them, and that peer is explaining to them what that process was like for them and kind of helping them to navigate to become a peer as well. And then we're looking at, hiring that individual, having them volunteer with us to learn what they are experiencing. So would that still, if they come on volunteering with us, would that still be something we can bill for Medicaid, because they're in a volunteer role, but that's part of their goal as a pathway to employment as a certified peer counselor?
I am not 100% sure, but I would say this. So are you asking if the peer the volunteer or an employee? Do you want to?
But is the individual that is working towards becoming a peer as a pathway to employment, but now they're volunteering at the organization as a peer, but they're learning as well their skills in how to be confident and supporting someone else by modeling a shadowing with that peer or shadowing under another service that's the peer organization itself. It may not necessarily be as a PNA, but they're working as a peer, volunteering under other services that being provided.
Well, it's a big question, because a volunteer cannot be paid. We can't pay volunteers, and so if they're not CPCs yet, we can't bill Medicaid for these services. So we can only bill Medicaid for services provided by a CPC that is an AAC, so agency affiliated counselor. So we can't bill for services that are provided by someone who is not that. So, and this might not answer your question, but I would love to maybe find you later, or you find me and email me, and we can keep talking about it, or schedule a meeting and talk about it more.
Okay,
if you're okay with that.
Yeah.
Can I add in really quickly, Juanita?
Yeah.
That if somebody identifies as a peer and they have been accepted on our wait list for, maybe they have a training in 2 months.
Mhm.
If that person, they can be, after they're trained, that person can bill for Medicaid before the agency affiliation. However, the funny piece behind that is that if the billing happens through Medicaid for peer services and that person is unable to become agency affiliated through the Department of Licensing or Department of Health, excuse me, then all of the money or all of the billing will have to be paid back to Medicaid. That's the up and down on that one.
Okay, so what about, because we're not a behavioral health agency, but we are a peer-run organization, and we're going to be applying through the Department of Health to become a behavioral health peer-run organization. So they're not going to, is that still that individual be agency affiliated once that application has been completed and approved? Because we are a peer-run organization, not necessarily a behavioral health agency. If that makes sense.
That makes a lot of sense. I would really love to have this conversation with you and Shelly offline if possible, so that way we can let her keep going with her presentation. But I absolutely, those are really fantastic questions, and I would really love to invite you to have a meeting with us.
Okay, that'll be great. Thank you.
Awesome.
That would be great. Yes, thank you. And Ronita, we saw your presentation in the COD conference, and that was very inspiring, and thank you for that.
Okay, thank you.
So I see Patty has her hand. She's still.
Hello. Hi. Thanks. So I appreciate this information. This has been very helpful. All the WACs that you provided and the Siri information and such. It leads me down the next step that I was looking at this week. And our team was looking at, the FCS funding opportunity that's out there right now to support our recovery community in a further outreach step of helping the individuals to using the facility, correct? So with that, it led me to questions in regards to the billing of services by the certified peers, by the CPC. And I found it interesting. So the H codes are the ones that you would be using. And there's an additional H codes that I found through research that also could be applied with the CPC services if properly documented and the CPC is properly used in the capacity as it's rendered in the WAC, right? So what I'm wondering that I guess my thought is, when I reached out to even our certified billing person, right, who does all this, there was still the unknown, because this is, it's like it's evolving. It's in a constant world of change and expansion of what can or cannot be built. And I'm thinking it would be really great if there's a way that you could do kind of an alignment, of here are some of the H codes that go beyond what the FCS funding does. So for us folks that are in a clinic-based, meaning you've got your CPC in a mental health or in a primary care, whatever the setting is, that it's already in a health facility that has your MCO contracts, or they don't have MCO contracts, they're just standard. Either situation, because that's a lot of the questions that I got back is, well, how will this implement our current MCO contracts and billing? Is this allowed? I'm not really sure, because it's still so new. There's so many things happening there. So I'm wondering if you, as the healthcare authority representative, you could provide some assistance in kind of a chart that would show, here's the code, here's the purpose. This is what a charting example could look like, because really what we're needing to do is we're needing to train these individuals as well to, be lifted up to that level of being able to properly account for their activity and their encounters, and it's gonna provide further evidence as to the value that they bring and the impact of the health outcomes.
Yeah, I think that's a wonderful question. Thank you for that. I was so confused with codes when I was still working in my agency. There are the codes and the modifiers, and if you do this and that, you add this to that. It's super confusing. I am up for the challenge, and I can connect with the billing and coding department and see what I can find out for you and share that with everyone. So, and specifically with you if you're interested in that. Yes, I will try to find out more about that. Absolutely, yes. And I'll connect with you. I know we are trying to connect as it is right now, Patty. So let's see if we can, I will find anyone who's interested and publish that.
Okay,
Yeah.
thank you. I appreciate that. Thanks.
Yeah, of course. Benjamin, do you have a question? I saw your hand.
I do. Can you go back one slide?
Yes, let me just, are you still, can you still see my slides?
I can.
Okay. Is this the one you were looking for?
The one before that.
Is this the one?
It's frozen, I think.
Oh. Okay, let me do this again, I think. Okay, how about this one?
Oh, I'm not seeing a difference.
It's still on the double arrow, Shelly.
Yeah.
Oh, there we
Okay.
go. Try it went. Oh, we just saw it again.
Yeah.
The service support voluntary is a service.
Oh,
support
Is that
so
the- okay.
I wanted to talk a little bit about the fourth issue. Is the peer support focused on the person's goals, the participants, not the agency's goals? And as a peer, this is one of the most difficult parts to deal with, because a lot of times the participants' goals aren't really that healthy. And I found oftentimes fueled or guided by an SUD issue.
Mhm.
But as a peer, I'm just supposed to be supportive of the goals that they're seeking, and it's sometimes contrary to agency goals, and sometimes it's also contrary to what might also be court mandated.
Yeah.
And so this, from the standpoint of a CPC, has always been difficult. It's very hard to come up with a way to model recovery that also hopefully is guiding them towards making a different decision that would be healthier for them, without actually kind of having it be my goal. That's one of the trickiest parts for me. But sometimes, particularly when something is, let's say, court mandated, I run into a difficulty with having to just bluntly tell someone that that's not going to, that can't work because of the court mandate. And I find myself veering more into the role of possibly a case manager, or a different part of the team. And depending on also the agency, peers in some agencies also take on case manager roles, and in others they do not. And this is just something that's an issue. I'm appreciative of this training, particularly for those that supervise peers. In the last place I had a supervisor that didn't even know what a peer was.
Yeah.
And that was very difficult. But I'd also like to point out that a lot of times team members don't know what peers are. And that puts difficulty both on the peer and the person supervising the peer, when the other members of a team don't really understand what the peer is and what their role is. And
Yeah.
Anyway, I just wanted to bring that
Yeah.
up. As peer roles grow exponentially as we move forward, this will also probably become more of an issue. And I just thought
Absolutely.
that if the
Mhm.
healthcare authority could come up with a specific training for peer supervisors to teach other team members about the peer role.
Absolutely. And thank you, Benjamin. And we don't have a lot of time, so I'll just say in 1 minute, we have these trainings. This is the OPS training that I'm providing for supervisors. And part of the training is how to navigate those systems, how to support the peers in integration and preparing the agency as far as culture shift, as far as letting everyone know what the peer role is, as far as recovery-oriented approaches that are being modeled throughout the agency. And so this is something that we're trying to do more. Obviously, supervisors need to be open to that and want to come to this free training. I heard you talk about the goals, and I think that's a valid, huge thing to talk about. What I would like to do now, since I didn't arrive to the end of my presentation, but that's okay. If you could write in a couple of words in the chat what you would like to hear more in the next webinars, I would love to hear your opinion and accommodate that. I'm thinking right now what I want to do next time is to talk about some things that supervisors want to be aware of in supervision as far as the peer role. I think we're going to talk about those goals, Ben, that you were mentioning, maybe how to navigate conflicting goals. We can talk about the peer role drift, which I didn't arrive to today. We can talk about integration of peers. We can talk about a lot of these other things. I'm just going to prepare another presentation about these topics that we didn't reach yet today. I thank you all. We are at the end of our time and I want to respect everyone's time. Please feel free to write in the chat anything that you would like or anything that you would like to see. And I appreciate you all. I'm sorry if I didn't get to your questions. I will read them and try to answer them and answer back to you in an email. So thank you very much. Have a nice day.
Thank you.
Thank you. Have a good day.
Thank you.